Imagine walking into a really busy hospital ward. The alarms are beeping down the hall. Nurses are rushing past with clipboards.
Right, the standard sort of clinical chaos.
Exactly, yeah. And right in the middle of all this frantic movement, a patient is standing perfectly still.
Just completely frozen.
Completely frozen. They are locked in this really awkward, unnatural pose. Perhaps one arm is just raised halfway in the air and their neck is craned to the side.
And they aren't speaking at all.
No, not a word. Their eyes are open, but they aren't scanning the room or, tracking you as you walk by.
Which is incredibly unsettling if you aren't used to it.
Oh, absolutely. And if you walk up to them and gently lift their other arm higher into the air, they don't resist. They just leave it there.
Hovering.
Yeah, hovering, defying gravity like a wax figure. And, for a century, the medical establishment looked at a patient presenting exactly like this and saw a refusal of will.
Yes, they saw it as psychological stubbornness.
Right. They thought it was this intentional barricade erected against the outside world. But inside that patient's brain, it is not a psychological choice at all, is it?
No, not even slightly. It is total catastrophic neurochemical gridlock.
And that is exactly what we are getting into today. Welcome to our deep dive into Kaplan and Psychiatri's comprehensive textbook of psychiatry, specifically Chapter 2.15.
We are looking closely under the hood of Catatonia today.
We really are. And, our mission here isn't just to recite the textbook to you. We are going to synthesize this material to help you build solid mental models.
Right, because we want to clarify the underlying mechanisms so that when you actually see these bizarre presentations on the ward, your clinical reasoning is sharp.
And immediate. Because psychiatry is so much more than just a list of diagnostic criteria in a manual. It's the study of how the brain, the mind, and experience interact.
And crucially, how the intricate process can go spectacularly wrong. Catatonia is arguably one of the most visually striking and fundamentally misunderstood syndromes in all of clinical practice.
Which is wild when you think about how long we've known about it. But we look at that profound immobility, that silence, and we just naturally assume the engine has failed.
Exactly. We assume the patient lacks the drive or the energy to move. But the engine is actually running.
It's running dangerously hot in many cases, right?
Spot on. It is the regulatory systems, the structures controlling that engine that have completely collapsed. It challenges you as the clinician to look far beyond mere appearances.
Because what looks like opposition or some severe behavioral disturbance is actually a profound disorder of the brain's motor and regulatory networks.
It's a failure of function, not of will.
Right. So let's ground this right away with a structural metaphor. Think of the brain's cortical and subcortical circuits as the traffic light system in a really massive, bustling city grid.
I like this analogy.
Yeah, so to keep traffic flowing, and by traffic I mean the flow of physical actions, speech, thoughts, emotional responses, you need a delicate, perfectly timed balance.
You need your green lights and your red lights.
Exactly. Green lights represent neurological disinhibition, so the initiation of movement. And the red lights represent neurological inhibition, the termination of an action.
A finely tuned system of go and stop. And, just like in a city, the green lights don't actually work unless the red lights are also functioning to stop the cross traffic.
That's the crucial part. So what happens if the central computer glitches and every single traffic light in that city turns green at the exact same time?
Well, the cars don't just speed up.
No. Traffic rushes into the central intersections from every possible direction simultaneously, and the result is total impenetrable gridlock.
Nothing moves at all.
The system is just jammed.
Yeah.
So when you see a patient frozen in a catatonic stupor, they haven't run out of fuel there at that jammed intersection.
The system of action is profoundly, dangerously dysregulated, and the clinical reality really does map onto that metaphor brilliantly.
Right. So how does the text actually define it at its core?
At its core, the chapter defines catatonia as a neuropsychiatric syndrome characterized by distinct abnormalities in the initiation and/or the termination of motoric and behavioral functions.
Okay, initiation and termination.
Yes, and it also heavily involves cognitive, emotional, and autonomic dysregulation. The chapter actually provides this fantastic central phrase to describe this overarching deficit.
That's the phrase.
A loss of executive volition.
Executive volition. Let's pull that apart a bit. What exactly does it mean neurologically to lose executive volition?
Well, it refers to the executive control of desired initiation and termination of functions. We often We take for granted that when we want to pick up a cup of coffee, our brains sends a signal, clears the path, and our arm moves.
And when we want to put it down, we just stop.
Right. Executive volition is that higher order, top-down control.
Right.
When it breaks down, the patient literally loses the ability to start a movement they desperately want to make.
Or they lose the ability to stop a motor loop they don't want to be executing.
Exactly. And the real tragedy of this syndrome is that getting the medical establishment to agree on what executive volition is and what catatonia actually represents has been nothing short of a massive historical custody battle.
Oh, the history section of this chapter is wild. Reading it is essentially like looking at a projective test for the fields of neurology and psychiatry over the last 150 years.
It really is.
Yeah.
Whatever the prevailing medical dogma of the decade was, that is exactly what catatonia was forced to be.
Right, forced to fit the mold.
The historical timeline is vital, though, because it explains why so many clinicians today still harbor so many misconceptions.
So let's trace the lineage back. The text starts in 1874, right?
Yes, 1874. The first systematic formal description came from a German psychiatrist named Karl Ludwig Kahlbaum. He originally described it as tension insanity.
Tension insanity. I mean, it sounds dramatic, almost sort of theatrical.
It does sound Victorian. But Kahlbaum was remarkably astute, perhaps much more so than many of his successors. He conceptualized mental illnesses as state course entities.
Meaning he looked at the longitudinal picture?
Exactly. He looked at the entire long-term trajectory of the patient. He noted that catatonia had a distinct relapsing and remitting course.
Okay.
But his most crucial observation, and this is the one that the field subsequently forgot for nearly a century, was that catatonia was strongly associated with both mood disorders and organic diseases.
Organic, meaning underlying medical or neurological conditions.
Right. He recognized it as a broad, overarching syndrome. And he noted it actually had a generally good prognosis if that underlying cause could be managed.
But then, of course, the turn of the century hits, 1899, and Emil Kraepelin enters the picture.
Kraepelin. He was obsessed with categorization and prognosis.
He really was. And he decided to lump catatonia entirely under the umbrella of dementia praecox, which was his early term for what we now call schizophrenia.
Right. He heavily emphasized the negativism and the contrary behaviors of the patients. And unlike Kahlbaum, Kraepelin predicted a chronic deteriorating course with a very poor prognosis.
He essentially took this broad treatable syndrome and condemned it to the chronic schizophrenia ward.
He did. And that narrow categorization was deeply cemented in the early 1900s by Eugen Bleuler.
Bleuler, right. The man famous for coining the term schizophrenia, which literally translates to splitting of the mind.
Now, you have to remember, Bleuler was operating in an era where psychoanalysis was quickly becoming the absolute dominant lens through which all psychiatric distress was viewed.
The Freudian era.
Exactly. So when Bleuler looked at a rigid, mute, posturing patient, he wasn't looking for a neurological circuit jam.
He wasn't looking for traffic lights.
No, not at all. He believed these physical catatonic features were purely the somatic manifestation of extreme subconscious ambivalence and intense internal psychological conflict.
Okay, wait. So if the patient was standing entirely frozen, refusing to speak, Bleuler's framework suggested they were just simply locked in a psychological battle.
Yes, a battle between wanting to interact and being utterly terrified of interacting. He essentially rejected the idea of a physiological organic cause altogether.
That is staggering. The motor signs were just symbols of psychological distress to him.
Just symbols. And this really underscores the profound danger of medical dogma. Because Bleuler was so highly influential, this psychoanalytic view of catatonia persisted for decades.
The diagnostic manuals officially classified catatonia as nothing more than a subtype of schizophrenia for, almost a century?
Yes. And the real-world consequence of that classification is horrifying when you think about it.
Because if a patient was brought into an emergency department in the 1950s, completely mute, rigid, and staring,
the admitting doctors would immediately assume, well, this is end-stage schizophrenia.
Right. They wouldn't run blood tests, they wouldn't look for a brain tumor or an acute viral infection or some severe metabolic crash.
They completely ignored organic etiologies because the textbook explicitly told them it was a psychological problem. The clinical blindness was systemic.
And the story gets even more complicated in the 1930s, doesn't it?
It does. Clinicians discovered that introducing sodium amobarbital, which is a potent sedative, could temporarily relieve catatonic symptoms.
The patients would suddenly wake up and talk.
Yes. But instead of seeing this as a massive, glaring clue to a neurochemical mechanism, they just used it as a temporary management tool to feed the patients.
Wow. And then the era of modern psychopharmacology arrived in the 1950s.
Right. Psychiatric wards changed dramatically with the introduction of early typical antipsychotics. And by the 1970s and 80s, you actually had prominent academics like B. Mahendra publishing papers claiming that the syndrome of catatonia had simply disappeared.
I mean, how does an entire medical field convince itself that a severe life-threatening syndrome has just vanished into thin air?
Well, because they had developed a collective blindness to its motor signs.
Right.
If you genuinely believe catatonia only exists as a rare subtype of chronic schizophrenia, and you are heavily sedating all those patients with early typical antipsychotics anyway.
You just stop actively looking for the subtle physical signs.
Exactly. And if you don't look for it, you don't diagnose it. It wasn't until the 1970s, 80s, and 90s that a dedicated group of clinician researchers finally initiated the modern liberation of the diagnosis.
Pioneers like Alan Gellenberg, Michael Allen Taylor, Richard Abrams, and Max Fink.
Yes, Fink especially. They had to act as medical archaeologists and to basically rediscover Kaldam's original findings from 1874.
They rigorously reviewed the clinical evidence, observed patients across different hospital wards, not just psychiatric ones, and they realized the field had made a massive categorization error.
They proved definitively that catatonia cuts across diagnostic boundaries. It is associated heavily with mood disorders.
Far more often than with schizophrenia, in fact, which is a huge paradigm shift.
And crucially, they proved it is frequently precipitated by general medical and neurological conditions.
And thankfully, the diagnostic manuals finally caught up to the clinical reality. The DSM-5 completely liberated catatonia.
Yes, it is no longer just a subtype of schizophrenia.
It is now recognized as its own distinct clinical syndrome. You can diagnose it as a specifier for a psychiatric disorder, like major depressive disorder with catatonia.
Or bipolar disorder with catatonia, which is very common.
Right. You can diagnose it as a catatonic disorder secondary to another medical condition. Or, if the cause is still unclear in the ED, you can diagnose it as unspecified catatonia.
It finally has its identity back.
Yeah.
Which is absolutely paramount because
Right.
understanding its identity requires us to fundamentally understand its unique neuropathophysiology.
Okay, this is why we need to look under the hood of that traffic light gridlock analogy and examine the actual neurobiology.
Let's trace the wiring.
The chapter spends a considerable amount of time contrasting catatonia with other profound motor disorders, specifically akinetic Parkinsonism and neuroleptic malignant syndrome, or NMS.
Right?
The text uses this overarching framework of top-down versus bottom-up dysfunction. So how does a failure of movement in Parkinson's differ from a failure of movement in catatonia?
It's a critical distinction. Let's look at the bottom-up disorders first. So Parkinson's disease and NMS.
Okay.
In these conditions, the fundamental problem originates deep in the primitive subcortical structures of the brain. Specifically, there is an absolute lack of dopamine making its way from the substantia nigra up to the striatum.
Because in Parkinson's disease, the dopamine-producing neurons in the substantia nigra are physically degenerating and dying.
Exactly. And in neuroleptic malignant syndrome, the dopamine is there, but those antipsychotic drugs are physically sitting on and blocking the D2 dopamine receptors in the striatum.
So either way, the motor signal from the bottom simply fails to reach the top. The engine literally lacks fuel.
Right, that's bottom up. But catatonia is entirely different. The text makes it clear that catatonia is a top-down dysfunction.
The primary issue isn't that the substantia nigra forgot how to produce dopamine.
No, it is a massive failure of cortical-subcortical modulation. The higher, sophisticated cortical areas are failing to regulate the lower structures.
This is your traffic light system breaking down. The text highlights specific cortical networks involved here. The frontoparietal networks, the frontal limbic networks, and the anterior cingulate medial orbitofrontal circuitry.
Right, let's pause on the orbitofrontal cortex for a second, because just throwing around anatomical names doesn't really help us build a mental model.
Good point. Think of the orbitofrontal cortex as the brain's risk, reward, and social context evaluator.
It takes in the environment and decides what behavioral response is appropriate.
Right. When that circuitry fails, the patient loses the behavioral drive to react to their environment at all. But how exactly does a failure high up in the cortex cascade down to a patient physically freezing up in a hospital bed?
It is a fascinating cascading neurochemical domino effect. And the primary suspect at the top of this cascade is GABA, gamma-aminobutyric acid.
GABA, which is our central nervous system's main inhibitory neurotransmitter.
It is the red light in your analogy. In a healthy brain, GABA receptors in the cortex exert a steady, inhibitory control over deeper structures.
They keep things calm.
Yes. In catatonia, there appears to be a profound deficit in this GABA activity. Specifically, there is reduced GABA inhibition of GABA interneurons in the substantia nigra and the ventral tegmental area.
Okay, let's track this step by step for the listener. The brain loses its ability to hit the brakes on certain regulatory interneurons deep in the midbrain.
Exactly. And because those specific inhibitory interneurons are no longer being restrained by the top-down GABA A signals, they just fire uninhibited.
They go wild.
They do. And this downstream disaster paradoxically induces a state of profound hypodopaminergia, meaning dangerously low dopamine activity in the dorsal and ventral striatum, as well as the paralimbic cortex.
So let me get this straight. The lack of GABA at the top causes a functional lack of dopamine at the bottom.
Spot on. But that's only half the traffic jam.
Right, because simultaneously, this lack of GABA inhibition in the frontal corticostriatal tracts causes an upregulation of NMDA receptor activity.
And NMDA receptors are activated by glutamate, which is the brain's primary excitatory neurotransmitter.
The green lights.
Yes. So the patient is hit with a dual crisis. We have way too much excitation from the glutamate storm, an absolute failure of inhibition from the GABA deficit, and a resulting severe shortage of dopamine in the very subcortical areas that actually execute movement and motivation.
You have cars accelerating wildly into an intersection where all the red lights have failed, and the actual engines of the car, the dopamine, stall out in the chaos.
Total gridlock.
So if I'm a clinician listening to this, I'm thinking about the pharmacology, and an obvious question jumps right out.
Go ahead.
If the end result of this massive domino effect is a lack of dopamine in the striatum, which is the exact same end result as Parkinson's disease, why don't we just treat catatonic patients with dopamine-boosting drugs?
That's right. Why not just give them levodopa?
Yeah, why can't I just give them levodopa to replace the dopamine, just like I would for a Parkinson's patient?
It is a perfectly logical assumption, but it is precisely where understanding the top-down mechanism becomes a literal matter of life and death.
Because of the traffic lights.
Exactly. You cannot just pour fuel into a jammed intersection because the root cause in catatonia is a regulatory top-down failure. You have to fix the traffic lights first.
If you just add dopamine with a drug like levodopa, what happens?
The system remains utterly dysregulated by the glutamate storm and the lack of GABA. The brain won't know what to do with the extra dopamine. It might even make the agitation worse. Instead, you have to target the origin of the cascade.
You must restore the inhibitory red lights to the frontal corticostriatal tracts.
Precisely. We administer a powerful GABA agonist, most commonly a benzodiazepine like lorazepam.
Lorazepam.
When you flood the system with lorazepam, it binds directly to those top-down GABA A receptors and forcibly restores the normal inhibitory modulation.
A manual reset.
Yes. This manual reset paradoxically disinhibits the dopamine activity down in the striatum and suppresses the glutamate overactivity. You fix the traffic lights, and the traffic immediately starts flowing again.
It is an incredible physiological paradox. A massive dose of a benzodiazepine, a drug that would put a healthy person into a very deep sleep, actually wakes the catatonic patient up.
It restores their brain's regulatory balance.
And we aren't just guessing at the circuitry anymore, are we? We actually have modern neuroimaging evidence backing up these specific functional failures.
We do. Now, to be clear, you do not use a brain scan to diagnose catatonia in clinical practice.
Mm-hmm.
The diagnosis is entirely clinical.
Right.
But research imaging has provided crucial evidence. Computed tomography, or CT scans, have frequently shown cerebellar atrophy in these patients.
And what about the blood flow?
More dynamically, cerebral blood flow studies reveal a striking asymmetric imbalance. You see hyperperfusion, so too much blood flow in the left basal ganglia, and hypoperfusion, too little blood flow in the right parietal cortex.
The functional MRI data gives us even more specific behavioral correlations. The text notes that fMRI shows reduced right motor cortex activation, which corresponds directly to the physical motor signs we observe.
Yes, and circling back to our earlier point, it shows severely reduced orbitofrontal cortical activity,
which maps perfectly onto the intense affective withdrawal and the behavioral symptoms. The brain's evaluator is entirely offline.
And all of this complex neurobiology translates into the stark, varied clinical realities we see on the ward.
Because the brain's entire regulatory network is broken, the clinical presentation isn't just one monolithic flavor, is it?
No, not at all. It isn't always the frozen mute patient from the textbook cover. The chapter outlines 4 distinct subtypes of catatonia, and recognizing the differences is absolutely vital.
Let's walk through those subtypes, because if you don't know the varied presentations, you will absolutely miss the diagnosis. The first is the most classic, the stuporous or retarded subtype.
Yes, this is what most people picture. The stupor subtype is characterized by profound mutism, extreme social withdrawal, negativism, inhibited movement, rigid posturing, and endless staring.
The patient is profoundly immobile, just locked in their own physiology.
Exactly. But then there's the direct opposite, the excited subtype. And this presentation completely shatters the public stereotype of catatonia.
It really does, and it's heavily underdiagnosed, isn't it? Because it looks like a manic episode or acute drug intoxication.
It's very tricky. Excited catatonia presents with excessive, frenzied, and purposeless motor activity.
The patient might be relentlessly restless.
Yes, exhibiting bizarre stereotyped movements, disorganized speech, severe impulsivity, profound agitation, and even unprovoked combativeness. They appear wildly frantic.
The crucial clinical distinction here is that their activity isn't goal-directed.
Right. They aren't pacing because they are anxious about a specific thought or delusion. They are pacing because the cortical dysregulation is driving a chaotic, unstoppable motor loop.
Then we escalate to the most dangerous form, malignant catatonia. This isn't just a psychiatric issue. It is an absolute critical medical emergency.
Malignant catatonia adds profound, life-threatening autonomic instability to the mix. The patient's regulatory systems completely crash.
What does that look like on the monitors?
They develop a soaring fever, their blood pressure becomes wildly labile, spiking and plummeting unpredictably. They exhibit a racing heart, tachypnoea or rapid breathing, extreme diaphoresis where they're just sweating profusely.
And delirium.
And severe, unyielding muscle rigidity. Historically, before the widespread implementation of electroconvulsive therapy in the 1960s, the mortality rate for malignant catatonia was catastrophic.
The text says between 75 to 100%. It was almost universally fatal.
Yes. Today, with prompt recognition and intensive care, mortality is down to about 10%, but it remains incredibly perilous.
And finally, the text mentions a rarer, genetically linked form called periodic catatonia. This follows a cyclical, relapsing, remitting course where patients basically swing between mixed stupor and excitement.
What's fascinating here is the neurodevelopmental link. It has an autosomal dominant inheritance pattern linked to a specific locus on chromosome 15q15,
which is a genetic region also heavily associated with schizophrenia and autism spectrum disorders.
That genetic link highlights just how deeply rooted in fundamental neurobiology these presentations actually are, and what makes diagnosing all of these subtypes so challenging, yet so intellectually fascinating for a clinician, is the sheer paradox of the physical clinical signs.
Let's spend some dedicated time here because the chapter provides this massive, incredible table 2.15-3 detailing the specific signs of catatonia.
It's a very comprehensive list.
Reading through this list is like looking at a catalog of neurological paradoxes. I mean, how can a patient be completely, utterly unresponsive to the world, yet simultaneously so intimately physically connected to the examiner's actions?
That paradox is the absolute hallmark of the syndrome. Clinicians assess these signs across 3 distinct domains: motor, behavioral, and affective.
We use standardized scales for this, right?
Yes, like the Bush-Francis Catatonia rating scale, which is very popular, the Northoff scale, and the Bräunig scale. Let's contrast a few specific signs to see how that paradox manifests physically. Consider the striking difference between waxy flexibility and rigidity.
Right, let's break that down for the listener. Because on a textbook page, they just sound like similar concepts of stiffness, but to the examining physician actually holding the patient's arm, they feel completely different.
Entirely different. If a patient has pure rigidity and you take their wrist and try to bend their arm at the elbow, you will feel a constant, severe, unyielding resistance throughout the entire range of motion.
It is smooth but immovable, like trying to bend a solid lead pipe.
Exactly. But waxy flexibility, also known clinically as flexibilitas seria, is entirely distinct. When you first go to move their arm, you feel a strong, noticeable initial resistance.
Like a catch.
Right. But as you apply steady pressure, the joint suddenly yields, exactly like bending a thick wax candle.
And here is the most striking diagnostic part. Once you place their arm in a new, even awkward and uncomfortable position against gravity,
They simply leave it there.
it's like posing a mannequin in a department store. The internal drive to return to a natural resting posture is just gone.
It is quite surreal to experience at the bedside.
And then there is this incredibly mind-bending pair of signs, Mitgehen and Gegenhalten.
Right.
These sound like obscure German philosophical concepts, but they are highly specific, reproducible physical responses.
They are classic signs that demonstrate the total collapse of top-down control. Mitgehen is an extreme pathological form of passive cooperation.
How do you test for it?
Imagine you are the examiner. You place your finger under the patient's forearm and apply just the lightest feather touch upward pressure. The patient's arm will raise in the direction of the pressure.
Okay, but a normal person might do that if they think you want them to move.
But the diagnostic key is this. This movement happens even if you explicitly, loudly instruct the patient, do not let me raise your arm, hold it still.
Wow.
Their body obeys the physical, tactile cue of the examiner, completely overriding the verbal instruction and their own internal volition. They move with the examiner involuntarily.
Their motor system is essentially hijacked by the physical environment, and Gegenhalten is the polar opposite of that phenomenon.
Exactly. In Gegenhalten, which is sometimes called paratonia, the patient exhibits a resistance to passive movement that is precisely mathematically proportional to the strength the examiner applies.
So if you pull their arm gently,
They pull back gently. If you pull hard, they resist hard. The muscle tone is induced entirely by going against the examiner.
but again, this isn't conscious, is it?
No, it is crucial to understand that this is not a conscious fight. The patient isn't thinking, I'm going to resist this doctor. It is a physiological mirroring of resistance. The harder you push, the harder the subcortical circuit pushes back.
We see this hijacking in the behavioral signs too, don't we? With signs like echopraxia and echolalia.
Right. Echopraxia is the involuntary mimicking of the examiner's physical movements. If you cross your legs, they cross theirs.
And echolalia is the echoing of speech.
Yes. If you say, how are you feeling today? The patient responds, feeling today. This is automatic obedience taken to its absolute extreme. The inhibitory filter that normally stops us from echoing everything we see and hear is just broken.
But then, in that very same patient, just moments later, you might see profound negativism, where they do the exact precise opposite of what you ask.
Yes, if you say, please open your eyes, they squeeze them tightly shut. If you try to gently guide them to sit in a chair, they lock their knees and stand rigidly.
The contradictory nature of these signs is just staggering. And then there are the speech abnormalities. The text makes a really careful distinction between verbigeration and perseveration.
Clinical precision matters immensely here. Verbigeration is the mechanical, rhythmic, and entirely purposeless repetition of phrases, sentences, or even just sounds over and over, like a scratched vinyl record.
It has no goal and no communicative intent.
None. Perseveration, on the other hand, is when a patient repeatedly returns to the same specific topic or the same motor movement, even after the context has completely changed.
Right, so if you ask them what they had for breakfast, they say toast. Then you ask them what year it is, and they say toast.
Exactly. It's an inability of the brain to switch cognitive gears.
And we absolutely cannot forget the affective signs, the emotional manifestations. We see profoundly flat affect, staring into space with zero environmental scanning for 20 seconds or more.
We see intense, uncontrollable anxiety.
Or we might witness sudden, inexplicable combativeness that seems driven purely by an internal electrical storm rather than any external trigger in the room.
When you look at the formal DSM-5 diagnostic criteria for catatonia, you need to observe 3 or more of 12 specific signs from this massive list to make the diagnosis.
Stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerisms, stereotypy, agitation not influenced by external stimuli, grimacing, echolalia, and echopraxia.
That's the list.
And here's where it gets incredibly interesting for diagnostic reasoning. If you look closely at that DSM-5 list, notice what is completely glaringly absent.
There are 0 symptoms in the diagnostic schema.
None. This is a profound, fundamental point about catatonia. In almost all other psychiatric disorders, we rely heavily on symptoms which are the patient's subjective complaints.
We rely on the patient saying, I feel incredibly sad, or I'm hearing voices, or I feel panicked.
But in catatonia, the diagnosis is based entirely, 100%, on objective signs, things the clinician observes and physically elicits during an examination.
The patient is almost always incapable of reporting symptoms. You have to physically examine them, touch them, test their tone to actually find the diagnosis.
So if you are a clinician who doesn't actively look for these physical signs, if you just sit across the desk with your clipboard and expect the patient to tell you what's wrong, you are going to miss the diagnosis completely.
Absolutely. And the epidemiology data in the chapter tells us that is exactly what is happening globally. The text states that catatonia is common, but wildly
The
underdiagnosed.
statistics are actually quite sobering, aren't they?
They are. One major study cited in the chapter showed that when a dedicated psychiatric research team used a standard screening instrument like the Bush-Francis scale on every single admission, they diagnosed catatonia 9 times more frequently than the regular admitting hospital teams.
9 times.
9 times. That means on regular psychiatric and medical wards all over the world, the vast majority of cases are sitting right under our noses, completely unrecognized.
We're calling it treatment-resistant depression or severe psychosis when it's actually catatonia.
Right.
So who are these patients slipping through the cracks? If we look at the pie chart of underlying etiologies, where is this syndrome actually coming from?
It spans the absolute entirety of medicine. About 30% of cases are tied directly to mood disorders.
Very often these are patients in bipolar mixed states, right?
Yes, experiencing the energy of mania with the despair of depression simultaneously. Historically, as we discussed, we thought of schizophrenia, but today, primary psychotic disorders account for only about 15% of cases.
Which leaves a massive chunk unaccounted for.
Exactly. The real wild card, and the trap for the unwary clinician, is that between 4% and 46% of cases, depending on whether you are in a psychiatric unit or a general hospital, are caused by neuromedical disorders.
And Table 2.151 gives us an incredibly dense, frankly intimidating list of these medical mimics. It is a stark reminder that a psychiatrist must never, ever stop thinking like a general physician.
You've got infectious causes like viral encephalitis, HIV, tertiary syphilis, malaria.
You have autoimmune conditions like systemic lupus erythematosus.
You have severe metabolic and endocrine crashes, diabetic ketoacidosis, acute intermittent porphyria, severe hypo and hyperthyroidism.
Let's take diabetic ketoacidosis, or DKA, as an example of how a medical issue creates a psychiatric presentation, because I think that helps cement the mechanism.
Good idea.
Hmm.
DKA causes severe metabolic acidosis. That massive shift in blood pH actually alters the electrochemical gradient across neuronal membranes in the brain.
It changes the environment the cells live in.
Right. It can specifically shift NMDA receptor sensitivity, flooding the brain with glutamate and overriding the GABA inhibitory system. The metabolic crash directly causes the neurochemical gridlock.
Wow. Or take autoimmune encephalitis, like anti-NMDA receptor encephalitis.
Yes, in that case, the body literally produces antibodies that cross the blood-brain barrier and directly attack those very glutamate receptors we discussed earlier.
The neurology is inseparable from the psychiatry here. The list even includes poisonings, carbon monoxide, tetryphyl lead.
And crucially, medications and substances. Withdrawal from benzodiazepines or suddenly stopping dopaminergic agents like levodopa in a Parkinson's patient can easily precipitate a catatonic crash.
And the use of neuroleptics antipsychotic medications can cause drug-induced catatonia.
Even certain antibiotics like macrolides and fluoroquinolones or drugs of abuse like PCP, ecstasy, and synthetic cannabinoids are documented triggers.
This is why the differential diagnosis is the most critical phase of care. Let's put ourselves in the shoes of a clinician on a busy night shift.
Okay.
A patient is brought into the emergency department. They are mute, staring, sweating profoundly, and extremely rigid. How do you definitively differentiate this from someone who is severely delirious or having a brainstem stroke or experiencing a totally different adverse drug reaction?
This is where clinical heuristics and rapid pattern recognition are vital. Let's look closely at Table 2.15I4 on differential diagnosis.
Okay.
One of the absolute trickiest differentiations a doctor faces is distinguishing between neuroleptic malignant syndrome, serotonin syndrome, and malignant catatonia.
Because they all present with that terrifying triad, right? Severe rigidity, soaring fever, and altered mental status.
Exactly. They look incredibly similar initially.
Let's unpack those three, because confusing them can genuinely be fatal. Let's start with NMS.
NMS is essentially a drug-induced iatrogenic form of malignant catatonia. It happens almost exclusively after exposure to dopamine antagonists, like high-dose typical antipsychotics.
So the dopamine receptors are physically blocked.
Yes. The defining physical feature during your exam is extreme hyperflexia and that classic smooth lead pipe rigidity across all joints.
Now contrast that with serotonin syndrome.
Serotonin syndrome is caused by serotonergic drugs, SSRIs, MAOIs, or combinations of serotonergic painkillers. The key physical distinction during your exam: serotonin syndrome is characterized by hyperreflexia, so exaggerated, overactive reflexes.
In myoclonus, right?
Yes, myoclonus, which are sudden, shock-like muscle jerks. The muscles are twitchy and hyperreactive, not just locked in lead.
Plus the autonomic stuff.
Right. Serotonin syndrome almost always presents with significant autonomic gastrointestinal distress, like severe diarrhea and hyperactive bowel sounds. NMS and catatonia typically lack those prominent GI symptoms.
What about akinetic mutism? Because just based on the name, a lack of movement and a lack of speech that sounds exactly like the stuporous subtype of catatonia.
They look incredibly similar from the doorway. The patient lies in bed, they don't move, they don't speak. But if you walk in and actually examine them, the differences emerge.
What are we looking for?
In akinetic mutism, you do not see the bizarre posturing, the waxy flexibility, the echolalia, or the echopraxia. Crucially, a patient with akinetic mutism will have absolutely zero response to a benzodiazepine challenge. And if you do neuroimaging, you will almost always see macroscopic structural lesions in the medial frontal lobes or the anterior cingulate.
The core conceptual difference is this. Akinetic mutism is a profound lack of motivation or drive to move. The engine is off.
Exactly. Catatonia, as we established, is a failure of the executive volition to execute a movement the patient may desperately want to make. The engine is on, but the brakes are locked.
And we also have to rule out purely neurological catastrophes. Things like locked-in syndrome, where the patient is fully conscious and cognitively intact, but totally paralyzed due to a brainstem stroke.
In that case, you look for preserved vertical eye movements and rely on urgent neuroimaging.
Or non-convulsive status epilepticus, which is essentially a continuous invisible electrical seizure in the brain without the physical convulsions of a typical grand mal seizure.
For non-convulsive status epilepticus, an EEG, an electroencephalogram, is absolutely essential. In catatonia, the EEG is usually normal or just shows nonspecific slowing.
But in non-convulsive status epilepticus, the EEG will light up with continuous epileptiform discharges.
Right. Finally, we must differentiate delirium and severe dementia. Delirious patients lack the classic posturing and negativism.
Yeah, and importantly, giving a delirious patient a large dose of a benzodiazepine will almost always exacerbate their confusion and respiratory depression, making them much worse, not better.
Which brings us nicely to the most critical action-oriented part of this deep dive, management.
You have a patient, you suspect catatonia, and the chapter gives a cardinal rule here. Treat first, ask questions later.
Absolutely. Because malignant catatonia can be rapidly lethal, leading to severe rhabdomyolysis, where muscle tissue breaks down and clogs the kidneys, renal failure, deep vein thrombosis from immobility, and fatal pulmonary embolisms. You do not have the luxury of waiting 24 hours for a specialist MRI read or a comprehensive autoimmune panel to return before initiating life-saving treatment.
You secure the airway, support the vital signs with hydration, cooling blankets, and DVT prophylaxis, and you immediately initiate the diagnostic and therapeutic linchpin of catatonia care, the lorazepam challenge.
Yes.
So we talked earlier about why lorazepam works neurologically, resetting the GABA red lights, but what does the actual protocol look like in practice? This is known as one of the most dramatic, instantaneous interventions in all of psychiatry.
The standard evidence-based protocol is to administer 2 milligrams of lorazepam intravenously.
Via.
Phy administration is heavily preferred over intramuscular because of its rapid onset, and because IM injections can cause significant pain, which can further exacerbate the patient's internal fear and dysregulation.
Makes sense.
In most adults, you use a robust 2 milligram dose right away to avoid an equivocal halfway response.
You push the 2 milligram IV and then you just sit by the bed and wait.
You wait 30 to 120 minutes, and what you're watching for is commonly referred to in the literature as the Lazarus response.
The Lazarus response.
Yes. A patient who has been entirely mute, frozen, rigid, and incontinent for days or even weeks might suddenly relax their muscles, look around the room, make eye contact, ask for a glass of water, and begin to speak normally.
Wow. It is a profoundly miraculous thing to witness in medicine.
It really is. A positive response, meaning a rapid, observable reduction in the catatonic signs on your rating scale, is highly confirmatory of the diagnosis.
But I want to pose a scenario. You push the 2 milligrams of lorazepam, an hour goes by, and the patient doesn't wake up. They are exactly as rigid and mute as they were an hour ago. Does that mean your diagnosis was wrong? Is it not catatonia?
No, it does not. And this is perhaps the most vital clinical pearl in the entire chapter. A negative response does not rule out catatonia.
Walk us through why.
Think deeply about the pharmacology here. If you take a healthy neurotypical adult or even a highly anxious patient and you push 2 milligrams of IV lorazepam directly into their vein, they're going to be deeply, profoundly sedated. They will be asleep.
Right.
If your catatonic patient is given 2 milligram IV, and there's no change, meaning they aren't miraculously interactive, but crucially, they also aren't sedated. That lack of expected sedation is actually a highly significant clinical observation.
It points strongly toward the diagnosis of catatonia.
Yes, because their brain is so profoundly dysregulated, so hyperglutamaturgic and flooded with excitatory signals, that it just absorbed a massive dose of a powerful sedative without even blinking.
The system is so hot it just burned right through the brakes.
Exactly. In that scenario, the protocol dictates that you give another dose, sometimes escalating rapidly. And once a patient does respond, you don't just stop.
Because the underlying dysregulation is still there.
You have to schedule the lorazepam around the clock, sometimes requiring massive doses up to 20 or 30 milligrams a day, just to keep the traffic lights functioning while the brain heals.
But lorazepam, while miraculous, is often just a bridge. What is the definitive gold standard treatment for severe or refractory cases?
Electroconvulsive therapy, ECT.
ECT. Yes, ECT has an astonishing efficacy rate in catatonia, often cited around 90%.
It is highly effective and frequently life-saving, particularly in malignant catatonia or in cases where the patient's vitals are crashing and they don't respond fully to the lorazepam challenge.
Let's demystify ECT for a moment because it carries so much historical stigma. How does inducing a seizure actually fix this complex neurochemical gridlock?
Well, ECT induces a highly controlled, brief, generalized cerebral seizure under general anesthesia and muscle relaxation. This seizure activity causes a massive release of neurotransmitters, including dopamine, serotonin, and GABA.
Okay, so a massive flush of the system.
Right. But more importantly, it stimulates the release of neurotrophic factors like BDNF, brain-derived neurotrophic factor. The downstream effect of this is a profound resetting of receptor sensitivities.
It effectively downregulates those overactive excitatory NMDA receptors and upregulates the inhibitory GABA receptors.
Yes, it is the closest thing we have in medicine to a hard reboot of the cortical-subcortical circuitry.
Yet the text points out a massive, often tragic, logistical and legal hurdle in certain jurisdictions, particularly in the United States, regarding accessing ECT for these specific patients.
Yes, the legal roadblocks driven by historical stigma and outdated policy. Because a severe catatonic patient is entirely mute, rigid, and incapacitated, they physically and cognitively cannot provide informed consent for an ECT procedure.
Right.
In many medical situations, a surrogate decision-maker like a spouse, a parent, or a legally appointed guardian can consent to life-saving procedures on the patient's behalf. However, in some U.S. states, laws strictly prohibit surrogates from consenting specifically to ECT.
So you have a life-threatening medical emergency, a proven cure with a 90% success rate, and a family literally begging the doctors to save their loved one, but the law prevents the doctors from administering it.
It is a devastating clinical bind. It leaves severely vulnerable patients trapped in a life-threatening state. Clinicians sometimes have to rely on the brief, temporary windows of clarity provided by high-dose lorazepam to frantically discuss the procedure and try to secure informed consent from the patient directly before the drug wears off and they freeze up again.
It's a stark reminder of how policy directly impacts bedside medicine.
Absolutely.
Now, what about treating the underlying cause? Let's say you do the lorazepam challenge. The patient wakes up and they tell you they are hearing terrifying voices telling them the world is ending.
Okay, so the catatonia is clearly being driven by an underlying psychotic disorder, like severe schizophrenia.
Right. A clinician's first instinct might say, well, they are psychotic. I need to give them a heavy antipsychotic.
And that well-meaning instinct can be fatal. This is a critical, bolded warning in the text. You must treat and resolve the catatonia first.
Think back to the mechanism.
Exactly. If you give a standard, typical antipsychotic like haloperidol, which strongly blocks D2 dopamine receptors, to a patient whose subcortical circuits are already starving for dopamine due to that top-down GABA failure,
You can push them straight over the edge.
you take a tenuous neurochemical state and precipitate fatal malignant catatonia, or NMS. You must maintain the lorazepam, or ECT, to keep the catatonia at bay.
Only once the motor symptoms are firmly resolved do you very cautiously treat the underlying psychosis.
Yes, preferably with low-potency, second-generation atypical antipsychotics that have partial agonist activity, like aripiprazole, which are less likely to block dopamine completely.
And for those incredibly frustrating cases that are resistant to lorazepam where the GABA agonists just aren't enough, we can target the other side of the equation.
We can target that glutamate overactivity.
The text mentions using NMDA receptor antagonists like amantadine or memantine as adjunct therapies to the lorazepam.
Exactly. You attack the gridlock from both sides, boost the GABA red lights with lorazepam, and dim the glutamate green lights with amantadine.
And while you are aggressively treating, you are continuously running the medical workup outlined in Table 2.155.
You are drawing blood daily to track serum creatine kinase, or CK, which spikes dangerously high in malignant catatonia due to muscle tissue breakdown.
You run the EEG to rule out non-convulsive seizures.
You might perform a lumbar puncture to check the cerebrospinal fluid for anti-NMDA receptor antibodies to rule out autoimmune encephalitis.
The clinical vigilance required is immense. And there is one more absolutely fascinating, almost sci-fi diagnostic trick mentioned at the very end of the chapter regarding patients with severe disorders of consciousness, or DOC.
Yes.
We're talking about patients who have suffered severe brain injuries and are classified as being in a vegetative state or a minimally conscious state. The text suggests that catatonia can actually masquerade as a permanent vegetative state.
This is a bleeding-edge area of neuropsychiatric research. There is significant symptom overlap between profound stuporous catatonia and disorders of consciousness, mutism, staring, complete immobility, failure to track visually.
It looks identical from the outside.
A remarkable pilot study found that when some seemingly permanent vegetative patients were given a dose of zolpidem, which is the common sleep aid Ambien, but crucially, it acts as a selective GABA receptor agonist.
They paradoxically woke up.
They did. They regained temporary consciousness, spoke to their families, and interacted with their environment before the drug wore off.
The sleep drug woke them from a coma.
Yes. And the implication is staggering. These pilot studies suggest that some of these patients didn't just have irreversible permanent structural brain damage. They actually had severe, unrecognized chronic catatonia.
Their subcortical networks were intact enough to respond to the GABAergic modulation, but they were trapped in a permanent state of downregulation.
It forces us to entirely reevaluate how we assess patients with severe brain injuries.
It really makes you wonder how many patients sitting in long-term care facilities right now might be locked in a reversible neurochemical state.
It's a sobering thought.
Okay, we have covered a massive amount of ground today, moving from history to neurochemistry to the bedside. Let's distill the core key takeaways from this chapter.
First and foremost, catatonia is not a single monolithic disease. It is a broad clinical syndrome of motor, behavioral, and physiological abnormalities. It represents a fundamental breakdown in the executive volition to regulate action.
Second, it spans a massive clinical spectrum. It can present as profound stuporous immobility and mutism, or it can present as frenzied, hyperactive, and combative excitement.
Third, it is far more than just schizophrenia. It cuts across severe mood disorders, psychotic disorders, and a vast, complex array of neuromedical conditions, ranging from autoimmune encephalitis to drug withdrawal.
Fourth, and perhaps most importantly for the clinician, reversibility is its hallmark. Despite looking permanent, severe, and catastrophic, early recognition and aggressive treatment with GABA agonists like lorazepam and ECT are highly effective and routinely save lives.
And finally, misdiagnosing it, writing off a patient's physical presentation as psychological stubbornness, intentional opposition, or mere psychotic agitation severely delays life-saving care, pushes clinicians toward dangerous antipsychotic use, and risks fatal malignant progression.
So as we wrap up, I want to leave you with a final provocative thought to chew on. We spend so much time as clinicians looking at the objective physical signs, the waxy flexibility, the staring, the vital signs, because the patient cannot speak to us.
Right.
But what is the actual subjective internal experience of catatonia? The text notes that the limited literature we have from patients who survive and recover describes the experience as one of overwhelming primal fear.
They describe a sense of impending doom, of imminent death, and profound psychological defeat.
Researchers like Max Fink and Edward Shorter have even posited that this persisting immense fear may activate primitive evolutionary defensive mechanisms in the brain, like freezing when a predator is near, and that this primal fear loop may potentially sustain the catatonic state itself.
It forces us to ask a deeply philosophical question.
Exactly. If a massive dose of a targeted chemical or a highly controlled electrical current can instantly restore a person's ability to move, to speak, to engage, and to choose their actions, what does the syndrome of catatonia tell us about the fragile biological limits of our essentially human constructs of conscious awareness and free will?
It is a profound, lingering question that sits at the very intersection of neurology and psychiatry. And to ensure the dense clinical mechanisms and diagnostic pathways we've discussed today are firmly cemented in your mental models, let's transition to our learning reinforcement.
Brilliant.
I am going to pose 5 single best answer questions based on the core concepts of the text. Try to reason through them as we go.
Let's do it.
Question 1. A 45-year-old patient presents to the emergency department with marked immobility, waxy flexibility, mutism, and a refusal to eat or drink. You strongly suspect the stuporous subtype of catatonia. According to the gridlock analogy of catatonia's underlying pathophysiology, what specific neurotransmitter system is primarily experiencing a top-down regulatory deficit?
Okay, let me think through the circuit jaw. If we are looking at a top-down failure, we are looking for the red lights that have failed to stop the traffic. The brain's primary inhibitory neurotransmitter is GABA, and we specifically discussed how a lack of GABA inhibition in the frontal pathways fails to inhibit those interneurons down in the midbrain.
Right.
This is what leads to the downstream lack of dopamine and the spike in glutamate. So the primary top-down deficit is GABA.
That is exactly correct. The answer is GABA, specifically reduced GABA inhibition leading to downstream dopamine and glutamate dysregulation.
Excellent.
Question 2. You are on the ward and administer a 2 milligram IV lorazepam challenge to a profoundly stuporous, rigid patient. You wait 1 hour. The patient exhibits absolutely no change to their catatonic behavior. But crucially, you observe that the patient is also not sedated. Their eyes are open and their respiratory rate is unchanged. How should you interpret this specific clinical response?
This is the trap I definitely would have fallen into before reading this chapter. If they don't wake up, my instinct would be to say, well, it didn't work. It must not be catatonia.
The common pitfall.
But the key here is that they aren't sedated. If I gave 2 milligrams of IV lorazepam to a healthy nurse on the ward, they would be fast asleep. The fact that this patient absorbed a massive sedative without any sedation means their brain is incredibly hyper-aroused and hyperglutamatergic. So this lack of expected sedation actually means catatonia is highly likely.
Spot on. A negative or equivocal behavioral response without sedation does not rule out catatonia. In fact, the lack of expected sedation in what would otherwise be a sedating dose strongly suggests catatonia is highly likely, and the protocol dictates another potentially higher dose may be required.
Okay, what's next?
Question 3. A patient on the psychiatric ward abruptly develops severe muscle rigidity, mutism, a soaring fever, and severe autonomic instability with fluctuating blood pressure. You need to rapidly differentiate serotonin syndrome from neuroleptic malignant syndrome, or NMS. During your physical exam, which specific clinical sign points strongly towards serotonin syndrome and away from NMS?
Both are life-threatening, and both have rigidity and fever. But NMS is caused by dopamine blockers, so the muscles are locked tight. That's the lead pipe rigidity with hyporeflexia.
Yes.
Serotonin syndrome is an overload of serotonin, which makes everything hyperreactive. So I would be looking for twitching, shivering, and most importantly, hyperreflexia and myoclonus. Plus, they'd likely had hyperactive bowel sounds or diarrhea, which NMS usually lacks.
Excellent clinical reasoning. The answer is prominent hyperreflexia and myoclonus. NMS typically presents with hyperreflexia and smooth lead pipe rigidity. Question 4. During your physical examination of a mute patient, you exhibit a sign where the patient repeatedly raises their arms smoothly in response to very light feather touch pressure from your finger, even though you have explicitly and loudly instructed them not to move their arm at all. What is the formal clinical name of this specific sign?
This is the one that demonstrates the absolute loss of top-down executive volition, where the body obeys the physical environment over verbal commands. It's the extreme passive cooperation. That is Mitken.
Correct. The sign is Mitken.
And the final question.
Question 5, our final question. Why is the use of typical high-potency antipsychotics contraindicated as a first-line treatment for a patient presenting with catatonia that is clearly being driven by an underlying psychotic disorder, such as schizophrenia?
Because you have to respect the underlying neurochemical gridlock. Even if the patient is psychotic, their catatonic state means they are suffering from functional subcortical hypodopaminergia. Their striatum is starved of dopamine because of the GABA failure upstream. If I give them a typical antipsychotic like haloperidol, I am deploying a D2 dopamine receptor blocker into an area that is already starved of dopamine. I will basically throw gasoline on the fire and likely push them straight into malignant catatonia.
Perfectly stated. The answer is because blocking D2 receptors in a system already experiencing profound subcortical hypodopaminergia can drastically worsen symptoms, turning stupor into lethal malignant catatonia. You must resolve the catatonia first.
Please direct yourself back to the chapter to review these concepts in text. Here are the details of this episode.
Catatonia. Byline. Frozen or driven when the system of action becomes profoundly dysregulated.